Okay.
Yep.
The next talk is also very important, where we are dealing with this non-arrhythmic ECG changes. And for this, I invite Dr. Debabrata Bera. He is very energetic and also very enthusiastic about electrophysiology and ECG. So we also discuss a lot of cases between each us also. So I think Dr. Debabrata can begin.
At the outset, I must thank Guha sir and the UCD team for giving me this opportunity. And I also must thank respected chairpersons, especially giving me this opportunity to present in a session where Dr. Narasimhan just spoke. It becomes difficult for the presenter to speak after Dr. Narasimhan, but I have to do the difficult job. And second, what Narasimhan sir also said, that the presentation is predominantly made for physicians. Maybe most of the cardiologists who are present, it might be very basic. Please bear with me. So in next 15 or 20 minutes or so, I'll be discussing a few of the common ECGs which we encounter in day-to-day clinical practice. Now, probably it is very difficult to cover everything in 20 minutes, but I'll try to do my best. Although I have some of the ECG changes seen in COVID at the end, but I think there is a session separately for that. I might skip them or I might cover them if the time permits. So coming to my first ECG, it will be mostly ECG case-based session. Narasimhan sir is also there. Sir, please put in your thoughts if sometimes you want to interrupt me and put your comments. So if this ECG is being given sometimes to interpret or report, sometimes we might just keep it writing as a normal sinus rhythm. But if you look it carefully, there are very subtle clues which can give rise to specific clinical information that becomes more pertinent when you have a clinical history like this. Let's say this is a 45-year-old lady who is hypothyroid and a progressive shortness of breath is present. And you see this ECG is very carefully, if you see the QRS amplitude is varying alternately. So the QRS amplitude is reducing and increasing alternate beats, and it is called electrical alternance. This is one of a very classical sign for significant pericardial effusion or cardiac tamponade. For this patient, it was a large pericardial effusion. There was no evidence of tamponade, and just treating the which is a gross hypothyroidism with thyroid TSH level more than 100. And after treating that, the pericardial effusion got changed. So for this, if you look at, if you find some ECG like this, then Sujita, I am audible?
Yeah, very much.
So, so if you find some ECG like this, possibly the first possible investigation for you will be doing a echocardiography to confirm your diagnosis. Going to our next ECG. So this is a 46-year-old diabetic male who presents with acute chest pain of 4 hours. So as we can see here, there is gross ST elevation in the inferior leads 2, 3 and AVF. But more importantly, what you need to notice, the reciprocal changes in the anterior leads and specifically an AVL, which I have marked here. So this suggests that the patient is having an active ischemia. And from this ECG, we can make a rough localization of which culprit artery is involved here, but possibly we're not going to discuss that. The most important thing of this ECG is if you find such ECG, this patient is a candidate for revascularization, and he shall immediately be admitted and proceeding for revascularization strategy, either by thrombolysis or by primary PCI. So much difficult scenario, or I would say this ECG will give much information from to take here. A 67-year gentleman, he is a smoker and acute chest pain for 2 days, and you get a ECG something like this in emergency. So what do? Do you think he is a candidate for thrombolysis? Because we can see that there is a ST elevation from V2 to V5, even V6, but there is a presence of a deep Q wave in V2 to V5. So again, as I have shown in the last ECG, it is actually the other leads which will give you the exact answer whether this patient needs immediate revascularization or not. What you see here, there is a significant ST depression in lead 3 and AVF, which is possibly the reciprocal changes of the anterior lead ST elevated MI. So in a late presentation, let's say this patient has a pain for 2 days. So some might actually, many times it has been missed by physicians or cardiologists that this is a late presentation and there is no benefit of getting a revascularization right now, either medically or by pharmacoinvasive strategy. But actually it is the contrary. When you have such kind of reciprocal changes, this Q waves actually is of no importance. It is important to have this such ST elevation can happen even without active ischemia when the patient has a akinetic wall or aneurysm has developed. But in those patients, you should not have a reciprocal changes. When you have these reciprocal changes in presence of ST elevation, then irrespective of your Q waves here, the patient shall benefit from revascularization strategy. Sometimes the pain has started 2 days back when the patient was started having unstable angina. Let's say it hasn't occluded, but when you see this ECG, you know that the patient has occlusion, which has been pretty recent, let's say 3 to 6 hours, within 3 to 6 hours, and he shall benefit from revascularization strategy. Going to our next ECG, this is very, very clinically relevant again. So this is a 55-year-old lady who is hypertensive and is having a dyspnea on exertion. Occasionally, she has angina as well. Now, as she presented, and this is the ECG where a cardiologist has rightly mentioned that there is a significant ischemia in which is evident here in V2, V3, V4. This is something like a deep T-wave inversion, sometimes coined as Whelan syndrome, which I will be discussing in the next slide. Now, the patient has come in the COVID era and she doesn't want to get admitted. So what are the other options available? And we thought that can we do a TMT or a thallium scan or a medical management? So the importance of this ECG is this patient should not undergo any stress testing like a TMT or a thallium scan, or also should not be kept under medical management. The reason is this Whelan syndrome, which is a pattern when you find a deep inverted T waves or especially biphasic T waves. Let's say in V2 you find a biphasic T wave here, and this is suggestive of a critical left anterior descending artery stenosis. And these patients, unless treated immediately, are at extremely high risk for extensive ventricular MI over next few days to weeks. And most importantly, in these patients, if you do stress testing either by a TMT or dobutamine stress echo, you might actually invite a myocardial infarction, which you could have prevented by a early invasive strategy. So this patient definitely has to be admitted, has to be treated with early invasive strategy. Now coming to our next ECG is a 50-year-old gentleman, again a diabetic. He has a stable CKD with a creatinine of 1.8. He has a vague chest pain for last 5 days, but now aggravated over last 3 to 4 hours. Echo has been done just 30 minutes back, which is otherwise normal, no regional wall motion abnormality and grade 1 diastolic dysfunction. So what do you think could be the possibility in this ECG? Is it a normal variant, or is it there is a hyperacute MI or impending MI which is going to happen? Or is it possible the patient has a hyperkalemia because the patient already had a stable CKD? Or it can be early repolarization pattern or pericarditis. So again, as previous 2-3 ECGs, the answer lies not in the ECGs where the ST elevation is present, but in the other leads. If you look carefully in the other inferior leads, you find that this area, this ST segment depression, a slight depression, but most importantly, this angle, ST segment followed by a T wave ascending limb angle. If this angle is very acute, you should suspect that there is some ischemia in that zone, or in the reverse zone, there can be a possible impending occlusion. In comparison, if you look at lead 1, let's say the ST segment is flat, then there is a gradual slope of the ascending limb of the T waves. In contrast, in lead 3, you see there is an acute bend. This same patient, when there was a resolution of pain, you see the lead 3 has become a flat STT and followed by a gradual obtuse angle of this ST to T angle. So this suggests this is a relatively normal, but whereas this is suggestive of a critical significant lesion. So when the pain resolved, you can actually see that hyperacute UF changes has also resolved, and there is a kind of valence pattern. So this patient was having impending LAD occlusion, which was rightly picked up in the dynamic changes by the ECG and was finally done with angioplasty. Coming to our next ECG, this is a 60-year-old gentleman. He has a chest pain for 2 days. And when he has presented to emergency, the TROP-T is positive. What do you think is the most most correct approach? Shall you thrombolize him? Shall you go for an early angiogram, or shall you put him on injection heparin, or a conservative management? So looking at the ECG again here, it looks like there is a ST elevation, even a J point elevation in almost V2 to V6. But also we need to notice that the ST elevation is also present in lead 1, lead 2, AVF. So there is AVL also. So almost all leads having ST elevation and J point elevation, but the ST elevation is concave upwards. So this suggests possibly this is not a STEMI, or it is something else. In presence of a ST depression in AVR and a possible PR depression in many leads, this ECG is sine qua non for a pericarditis. So all the first three options, you cannot do thrombolysis. It can be fatal in this patient who already has a pericarditis. And even doing an angiogram or giving an injection heparin, thinking it as an acute coronary syndrome empirically, you might actually convert a simple pericardial effusion into a hemorrhagic conversion, which can be catastrophic. So this patient needs a conservative management for a pericarditis. And to emphasize that sometimes pericarditis can have a trop I or trop T elevation because of little involvement of the myopericardium. So this is just to tell us that the isoelectric segment in ECG is considered this TP interval, the end of T to the beginning of P. And whenever you are talking about PR segment depression, ST elevation, this has to be in comparison to this TP interval. Coming to another interesting ECG, which is also a classical one. Let's say a 65-year-old gentleman who is a diabetic and has a chest pain for 2 days. He has come to emergency, his trop T is negative. And this patient again has come in a COVID era, and he wants to go home because otherwise ECG is reported as non-specific STT changes. Shall we send him home, or shall we try for a thrombolysis or an early angiogram or an injection heparin? So if you look at it, in general, there is ST depression in lead 1, 2, AVL, 3, AVF, even V5, V6. The only place where is a ST elevation is there is AVR. And in V1, the ST is almost flat. So this ECG is, I'm just zoomed it for better visualization. If you see, the AVR has a ST elevation and almost all other leads has a ST depression. This ECG, unless proven otherwise, is equivalent for a left main critical coronary artery disease or a significant triple vessel CAD. This patient cannot go home without proper evaluation. And most of these patients have a significant lesion which I have to tackle immediately. Otherwise, there is a significant chance of MI and high mortality in subsequent few days to weeks. So just to remember that when you have a ST elevation and ST depression in, or ST elevation in AVR and ST depression in all other leads, it is something like a mirror image of a pericarditis. In pericarditis, you have ST elevation everywhere except in AVR and V1. This is something reverse of that. And in this situation, again, you have to follow a early invasive strategy. Coming to few of a simpler ECGs, this is a 50-year-old gentleman who is hypertensive, diabetic, and smoker, and he has a gradual dyspnea on exertion in NYHA class 2. So what we find here, the ECG has been reported by a physician that he has a lateral wall ischemia. He may be correct, but more so what we find here, the precordial lead voltages are quite high. I'm not going into the criteria. So the precordial lead voltages are high. And what you find in the lateral leads is STT changes, ST depression and T-wave inversion, which is again a gradual slope kind of thing. ST is gradually depressing into a T-wave inversion. This is generally seen in hypertensive heart disease or significant severe or moderate to severe aortic stenosis. Aortic regurgitation, if they have, there is generally a volume overloaded condition, but they usually have a Q wave in lateral leads, which is not present here. This is most likely a concentric LVH of a patient. In contrast, this patient is a 40-year-old gentleman who has again a dyspnea on exertion and angina. What is here? This is very, very important in contrast to the previous ECG. What we see here, there is a deep T-wave inversion, which is very, very symmetrical, and it starts after a relatively stable ST segment, and suddenly there is a very symmetric deep STT changes. Whenever we see this, we know that this patient might have apical hypertrophic cardiomyopathy. But of to do a cardiac MRI and dig a little more detail to find out whether there is a true apical hypertrophy in the segment of left ventricular apex. It can be also involve the right ventricular apex, but predominantly LV apex is involved. And this kind of ECG, this patient, you see there is no risk factor, otherwise no non-diabetic, non-hypertensive. Most of the time the diagnosis is apical hypertrophic cardiomyopathy. Now coming to a different segment of patients, this patient is a 75-year-old lady who is diabetic, and he got admitted to emergency with a history of syncope, and she was found unresponsive at home. And when she was brought to emergency, she was immediately intubated because of the bad neurological status, and this is the ECG. And you get a call from your emergency resident that the patient has a ST elevation. Possibly she had a ventricular fibrillation at home from an impending MI, and you need primary angioplasty for him. So what will be your thoughts on this ECG? Will you proceed for an immediate coronary angiogram, or a primary angioplasty will activate the cath lab, or you will go for insulin dextrose, dialysis, ABG, or calcium gluconate? So whenever you see such kind of ECG, what are the findings? The QRS is very wide, and the QRS ascending limb has almost merged with the ascending limb of the T waves, and you do not find any P wave anywhere in the ECG. It is almost a very wide QRS complex, which is just preceding a sine wave pattern in patients with severe hyperkalemia. These patients, you have to act even before you get a cath lab report of potassium. Probably a quick ABG will give you a rough idea how is the potassium, but even if you don't have the facility of ABG, you can empirically give insulin dextrose and a calcium gluconate so that you get some time to stabilize the patient. Otherwise, these patients are going to through an immediate fatal ventricular arrhythmia from which you may not be able to salvage the patient. So this is not a STEMI, this is a hyperkalemia ECG. Once you treat them with insulin dextrose, K-bind, Astelin inhalation, medical management with soda bicarb, many of these patients who develop acute hyperkalemia also have acidosis, so you can treat with bicarb. You can have a little improvement on the ECG, and later on you can just find that there is a hyperacute. This is a classical ECG pattern of a hyperacute T wave, but this you find from the ECG itself you can roughly tell how is the potassium level. The third ECG I show categorized into a mild hyperkalemia of 5.5 to 6.5. The second one which I showed is moderate hyperkalemia, and the first one is almost classical ECG, typical ECG of a severe hyperkalemia, where you find a very wide QRS merging into the T waves. We occasionally come. I'll take another 5 minutes before I stop. So we occasionally find such ECGs when this patient was admitted with a congestive cardiac failure in CCU, and now he has improved, and this is a ECG which we just put a note the normal sinus rhythm. But if we need to look this little carefully, if you see here many of the ECG leads, you see the T wave is very flat, followed by a hump here. So this is possibly a U wave and a flat T wave. And these patients who are actually on high dose of diuretics, they can develop a severe hypokalemia, although not as malignant as hyperkalemia, but hypokalemia also needs to be treated immediately because there are so many drugs which can interact with them. So this patient had a potassium of 1.7 to complete the case. And coming to our next case, this is a 36-year-old lady who was admitted with pneumonia. Again, this ECG may appear normal, but when you look carefully, you find the T wave has come much later. So possibly there is a long QT, which may be congenital, which may be iatrogenic. So how to tell from a ECG that there is a long QT? Obviously, we have Bazest formula and several other formulas, but from eyeballing, if you have a RR interval here, and you drop a line just midway between the RR interval, if your T waves doesn't complete within the half of RR, you see multiple leads, the T wave is actually prolonging beyond that half of the RR interval. So you know that the patient has a long QT syndrome. Many things can cause acute long QT syndrome. I'll just highlight some of the important ones. We as a cardiologist or a medical person must be knowing. So, sotalol and amiodarone are known to cause long QT. Antibiotics like erythromycin, clindamycin. In fact, the previous patient was on clindamycin who had a prolonged QT. Many of the antipsychotic drugs, almost all of the hypokalemia, hypomagnesemia, hypocalcemia, they can cause a longer QT. Myocardial ischemia can cause long QT and torsades, and some of neurologic disease like subarachnoid hemorrhage. Coming to a couple of ECG examples where I can say it is one of the prototype of example. The most important finding here is a very prominent RV in V1 along with ST depression in V1, V2. So we can call it there is a prominent RV forces. The predominant causes are for let's say this ECG was a 40-year-old lady who was referred outpatient department for increasing SOB, and echocardiography suggested she has a primary pulmonary hypertension. It can be secondary pulmonary hypertension as well, where the patient can have a COPD and can have such prominent QRS complex in V1 along with ST depression like we find in LVH. This is a sine qua non for right ventricular hypertrophy. Just in contrast, this is another ECG of a patient. You look similar, but the slurring of the QRS complex in the beginning, this patient is asymptomatic. The slurring of the beginning of QRS complex tells you that this patient has a WPW syndrome who can have STD, secondary STD changes. And this slurring tells you that the patient do not have a right ventricular hypertrophy, rather he has a left-sided accessory pathway. Probably I'll finish or stop with this ECG because my time is almost over. So this was a case which I encountered in Hyderabad when I was working with Narasimhan sir. So this is one of a patient. He's a 25-year-old gentleman who went to a hospital saying that there is a little shortness of breath and uneasy feeling. And he was told that there is a sinus tachycardia and otherwise everything is all right. Maybe he is little anxious. He was a IT professional, so he can go home. And he went home. He felt that there is no improvement on the shortness of breath. He came in midnight and this is the ECG. In fact, in midnight when he presented to emergency, someone noted there is a small Q in V1 and did a trop T which was also positive. So what is the most possible diagnosis of this patient? Again, if you look into the ECG carefully, you see there is a right axis deviation. How do you know that? You see lead 1 has a deep S wave and also there is a QR in V1. This to suggest this patient has a right ventricle predominance in this ECG. And the possible options when a patient has a subacute sudden SOB is a pulmonary embolism. Indeed, this patient had a pulmonary embolism. On echo, he showed right ventricular dyskinesia, and it was confirmed on CT pulmonary angiogram that the patient has a pulmonary embolism and was treated with thrombolysis. So this ECG also shows one of a very rare but classical ECG pattern of pulmonary embolism. That is S1, that is predominant S1 Q3 T3. This is a predominant or prominent S in lead 1, Q in lead 3, and T wave inversion in lead 3. These just suggest that the right ventricle is overloaded, either pressure or volume overloaded, and it is one of the classical sign of which is seen only in 10% of pulmonary embolism cases. But this was one of those fortunate cases where we could pick up and treat him immediately. This is a ECG. I'll just finish with this ECG. They're just showing that this patient had a sudden headache and loss of consciousness followed by aphasia, and he was diagnosed to have a subarachnoid hemorrhage. And this ECG shows that it can mimic acute coronary syndrome with a deep T wave inversion, or some can tell that there is a long QT and treat them inappropriately. These changes are seen because of secondary to the subarachnoid hemorrhage and CVA. So we should not treat them aggressively with heparin or something which can be catastrophic. So I'll stop here. I'll be happy to take up any questions are there.
Thank you, Debabrata. Dr. Bappaditya Kumar is there. Bappa, are you there? Can't hear anything. Well,
yes, sir.
Yeah, give your comments and wind up the session.
It was a fine presentation. I would just like to mention that if Debabrata would have gone some few points regarding the localization of the MIs on ECG, it would have been better. But perhaps the time will not permit that.